Dermatomes. Are they reliable and specific? Much of what we perform with a neurological assessment is assumed to be tested and reliable, yet many of the concepts for these tests were based on logical assumptions related to what was known at the time, with only some basic science confirmation. More recently, many of the traditionally held concepts have been challenged, partly due to the empirical observations of clinicians being different than traditional tenets, and partly because of new approaches to testing these tests. Recently, just such an approach was utilized to evaluate the consistency of patients' report of radicular pain patterns based on nerve root levels for the low back and lower extremity. What becomes apparent is that the discretely packaged lines of dermatomes that are based on sensory innervation may not represent such a report of patients with radicular pain. First, let's look at the standard charts currently utilized. First, Sherrington studied dermatomes in rhesus monkeys by sectioning nerve roots above and below an intact nerve root. He then mapped the area of intact sensation. Forrester used a similar concept in humans who had suffered a nerve root injury. He found that human dermatomal maps were similar to the findings of Sherrington in rhesus monkeys. Then the Keegan and Garrett dermatome map was created in 1948 and shows neatly non-overlapping bands extending down from the midline of the lumbar spine to the lower extremities. The map was based on patients with disc herniation and diminished light touch sensation, which was tested by a light pin scratch. A total of 1,264 patients with disc herniations from L3 to S1 were studied, but only 707, or 56%, were confirmed at surgery. Although this is the most widely used map, it is also considered to be the most inaccurate based on more current studies. Thoracic and L1 and L2 dermatomes were not studied, yet they appear on the map. They stated that the areas of diminished light touch sensation for lumbar dermatomes extended from the proximal midline down, yet all newer studies point to only a consistency of distal loss with varied proximal loss. Clinical decisions are often made by correlating a patient's symptom distribution with sensory dermatomal maps. However, studies suggest that the referred symptom distribution from cervical spine and lumbosacral nerve root provocation is different from dermatomal maps. One such study was by Murphy, Hurwitz, and Carey. It was a retrospective study performed on patients with known nerve root involvement, entitled Pain Patterns and Descriptions in Patients with Radicular Pain. Does the pain necessarily follow a specific dermatome? It was published in Chiropractic and Osteopathy in 2009. For the cervical spine, except for C4, pain was non-dermatomal in 69.7% of cases of cervical radiculopathy. And for the low back, except for S1, pain was non-dermatomal in 64.1% of cases of lumbar radiculopathy. We'll see why S1 is the exception later. Some reasons why are primarily based on anatomical variation. A spinal segment does not equal all the nerves that go to that spinal nerve. For example, sensory nerve fibers in the C5 spinal segment may not contribute to the C5 spinal nerve. Nerve fibers transmitting different sensory modalities to the same skin areas may derive from different spinal nerves or different spinal segments. Overlap of innervation from two spinal nerves may result in no loss of sensation when one is compressed or damaged. Now to the current study. The title is Induced Lumbosacral Radicular Symptom Referral Patterns, a descriptive study published in the Spine Journal in 2019. The purpose of this study was to determine lumbosacral radicular symptom referral patterns induced using transforaminal epidural injections. This was an observational descriptive study. The patient sample included 71 consecutive patients with lumbosacral radicular pain undergoing lumbosacral transforaminal epidural injections at an outpatient interventional spine practice. Provoked symptoms were recorded first at final needle positioning, second at an injection of up to 0.5 milliliters of a contrast solution, and finally injection of up to 1 milliliter of a test dose of 1% lidocaine. Each subject drew the location of provoked symptoms on a diagram. The provoked symptom diagrams for each lumbosacral segmental level were combined to create a composite nerve root level-specific symptom referral pattern map. 4 nerve roots were tested at L1 and 8 were tested at L2, but because of the small number of subjects, composite diagrams and statistical analysis were not completed for those levels. For L3, we see that 15 nerve roots were tested. 4 did not provoke symptoms. 3 provoked symptoms on the anterior and 2 to the medial thigh. 5 provoked symptoms in the buttocks, and 4 provoked symptoms in the posterior calf. For L4, 40 nerve roots were tested. 12 did not provoke symptoms. 12 provoked symptoms in the buttocks, 8 provoked symptoms in the anterior thigh, and 7 provoked symptoms in the posterior calf. Let's compare this to the traditional L4 dermatomal path, which is primarily anterior. For L5, there were 34 nerve roots tested. 8 did not provoke symptoms. 4 provoked symptoms in the anterior thigh. 21 provoked symptoms in the buttocks, and 20 provoked symptoms in the posterior calf. Let's look at the traditional L5 dermatomal map. We can see here that it is primarily lateral thigh and lateral lower leg pain. However, only 4 had pain at the lateral thigh and 8 at the lateral lower leg. For S1, 16 nerve roots were tested. 5 did not provoke symptoms. 7 provoked symptoms in the buttocks. 4 provoked symptoms in the posterior thigh, and 5 provoked symptoms in the posterior calf. None were provoked in the anterior leg. If we look at the traditional pattern for S1, this is the only nerve root that follows the traditional pattern. So are these variations merely subjective, or are there anatomical variations that result in the differences? It is known that each area of skin in the upper and lower extremities is innervated by 2 or more spinal nerves. Intrathecal anastomosis between dorsal rootlets is also common. One study found that 22% of lumbar dorsal roots had intrathecal intersegmental anastomosis spanning one segment, which allows for sensory neurons with a ganglion cell at one dorsal root ganglion to enter the spinal cord at a level above or below. Transitional segments at the lumbosacral junction occur in 15% of patients, and those at the thoracolumbar junction occur in 4% of patients. Transitional lumbosacral segments show variation in radicular pain referral patterns and alteration in the function of the respective lumbosacral nerve root. So to the conclusion by the researchers, referred pain to the buttock, the posterior thigh, or the posterior calf may come from L3, L4, L5, or S1 nerve root segmental irritation. This is consistent with other studies. For example, after selective nerve root blocks, Nita et al. Found a continuous band-like zone of sensory impairment from the proximal lower limb to the periphery in only 42% of L4 blocks, 44% of L5 blocks, and in 92% of S1 blocks. And Bogduk, in a publication in Pain entitled On the Definitions and Physiology of Back Pain, Referred Pain, and Radicular Pain, gives a clinical warning. He states, quote, segments can be estimated only when radiculopathy occurs in combination with radicular pain. In that event, it's the dermatomal distribution of numbness, not the distribution of pain, that allows the segment of origin to be determined, unquote.